Welcome to our video on oncologic emergencies. Let's get started. In this lecture, we'll go over tumor lysis syndrome, hypercalcemia of malignancy, spinal cord compression, and cardiac tamponade. All of these can occur secondary to a malignancy, and they require immediate attention to prevent significant morbidity and even prevent death. And here's what we'll cover with each topic. Let's start with tumor lysis syndrome. This syndrome is characterized by lysis of tumor cells that causes rapid release of intracellular contents into the bloodstream, potentially leading to life-threatening electrolyte derangements and/or metabolic abnormalities. And it commonly occurs following initiation of chemotherapy for the tumors, especially those with high burden or rapid cell turnover. And tumor lysis syndrome usually starts with constitutional symptoms, so you're thinking like malaise or even nausea. And the release of large amounts of intracellular potassium into the bloodstream will lead to hyperkalemia, which in turn will lead to characteristic ECG changes. So, for example, peaked T waves. On the other hand, a release of large amounts of phosphate can cause sequestration of serum calcium. So all that phosphate binds up the calcium, and then the patient is hypocalcemic. And that low serum calcium will then manifest as tetany and seizures. And if that calcium precipitates with the phosphate, which makes sense that it would, because you're now getting calcium phosphate, then it could cause acute kidney injury from those calcium phosphate crystals. Lastly, release of uric acid from destruction of tumor cells will lead to hyperuricemia, which can predispose the patient to gout or even acute kidney injury from the uric acid crystals. So, there's a couple of different ways that the kidneys can be injured as a result of tumor lysis. It can be calcium phosphate crystals or uric acid crystals. Now here's an example of the characteristic ECG changes that can be seen in patients with hyperkalemia. Note the peaked T waves as well as the small, almost indiscernible P waves. And here's an ECG demonstrating prolongation of the QT interval in a patient with hypocalcemia. And let's zoom in on lead 2 to illustrate this point. Remember that a normal QT interval is about 0.44 seconds, or 2 big boxes and 1 small box. And the QT interval is measured from the start of the QRS wave to the end of the subsequent T wave. And also recall that each big ECG box is equivalent to 0.2 seconds, and each little ECG box is equivalent to 0.04 seconds. And if we look at this QT interval, note that it spans about 2 big boxes and about 1.5 little boxes, meaning that the estimated QT interval is about 0.46 seconds, and that's prolonged. Though this is just an estimation, it's actually pretty close to the QT interval that was reported by the ECG machine, which was 0.47 seconds. Given the severity of tumor lysis syndrome, clinicians should strongly consider prophylaxis with IV normal saline for all patients who are at risk of developing this disorder. And the goal is to flush all of the electrolytes out of the bloodstream and the kidneys in order to prevent tumor lysis syndrome from happening in the first place. That being said, if tumor lysis syndrome develops, the treatment approach involves several important steps. So first, clinicians should consider initiating IV calcium gluconate in order to stabilize the cardiac membranes, and that's especially important if the patient has proven hyperkalemia and they have the ECG changes suggesting hyperkalemia. Again, those peaked T waves. Second, clinicians should act quickly to reduce serum potassium levels using insulin and glucose. And then insulin will drive extracellular potassium back into the cells, and the glucose will just prevent the insulin from causing hypoglycemia. So you don't want to create hypoglycemia when you're trying to fix this hypercalcemia, so you just give glucose with the insulin. Third, patients should once again be given IV fluids to flush out the massive amounts of electrolytes and the various metabolites that enter the bloodstream upon destruction of those tumor cells. So it's almost like diluting out all that stuff. Now fourth, clinicians should place patients on continuous telemetry in order to monitor their heart rhythms so that you can promptly address any arrhythmias that may pop up. Now lastly, if necessary, clinicians should also act to reduce the uric acid levels using medications like allopurinol, rasburicase, or febuxostat. Let's do a quick question to apply what you've learned so far. How will the levels of serum potassium, phosphate, and calcium change in patients with tumor lysis syndrome? So basically, this is just a review to think, okay, serum potassium increases, serum phosphate increases, and as a result of the phosphate increasing, free calcium will actually decrease. And again, all of this happens And the reason that the potassium and phosphate increase is because the cancer cells just released them when they were killed by the chemotherapy. And then the reason the calcium decreased was, as I just mentioned, a result of the free phosphate binding it up. Now let's discuss hypercalcemia of malignancy. Hypercalcemia of malignancy is characterized by elevated serum calcium in the setting of an associated malignancy. Common scenarios include multiple myeloma, and that usually presents as hypercalcemia with pancytopenia, and squamous cell carcinoma of the lung, which is associated with the paraneoplastic production of parathyroid hormone-related peptide, or PTH-RP, and lastly, breast cancer metastases to the bone. So all of these things are common scenarios for hypercalcemia of malignancy. Now, the clinical features of hypercalcemia can be remembered with the mnemonic stones, groans, bones, and psychiatric overtones. In other words, the hypercalcemia can cause symptoms such as kidney stones, abdominal pain, bone pain, and various neuropsychiatric symptoms. But how do you treat this? Hypercalcemia of malignancy warrants immediate treatment in the setting of either symptomatic hypercalcemia, so that is the stones, groans, bones, psychiatric overtones, or severe hypercalcemia, which just means the level is crazy high. So you're thinking 14 or greater. And the initial goal of treatment is to promptly reduce calcium levels, and that can be achieved with aggressive normal saline hydration, and you can consider calcitonin. Clinicians should also consider giving loop diuretics for volume overloaded patients, such as patients with cirrhosis, and the idea is to get the calcium and extra fluid out of their system. Lastly, clinicians may use bisphosphonates, such as alendronate, as more of a long-term treatment method for the hypercalcemia. So again, just thinking clinically, they've got this high calcium level, you want to reduce it, but then also recognize that in addition to being an acute issue, you want to prevent this from becoming a long-term problem again and again. And since we're dealing with malignancy, you expect it to be a chronic and recurring issue. And on the topic of bisphosphonates, as a quick reminder, bisphosphonates work by inhibiting osteoclasts in the bones, and that prevents further breakdown of bone, which means less calcium being released into the bloodstream. Let's do a quick question. In patients with hypercalcemia of malignancy, will serum parathyroid hormone, PTH, be low or high relative to normal? So in hypercalcemia of malignancy, the serum PTH will be low due to the negative feedback exerted on the parathyroid glands by the high serum calcium. And that actually contrasts to the hypercalcemia that occurs as a result of primary hyperparathyroidism. And in that issue, there's excessive production of PTH that drives the spike in serum calcium. And knowing the negative feedback from hypercalcemia of malignancy on the parathyroid hormone release is super important and can really help you on exams. Now let's move on to spinal cord compression. Spinal cord compression is characterized by compression of spinal nerve roots secondary to epidural tumors. Now, common cancers associated with spinal cord compression include multiple myeloma, breast cancer, lung cancer, and prostate cancer. And the clinical features of spinal cord compression usually start with a progressive back pain, and it's typically worse at night. They can also have cancer-related constitutional symptoms, and those you think of weight loss or fatigue. And it could also lead to upper motor neuron symptoms, such as muscle spasticity, or increased tone, increased reflexes. The diagnosis of spinal cord compression is confirmed with emergency MRI as soon as you suspect it clinically. And once you've diagnosed it with an MRI, then you want to treat it. And how you do this is you start with intravenous high-dose steroids, and the goal is to promptly reduce the size of the tumor and prevent further damage to the nervous system. And patients should subsequently be either referred to a radiation oncologist so that they can get some radiation therapy, or scheduled for surgical decompression with neurosurgery in order to definitively treat their spinal cord compression. In other words, those IV steroids are just a short-term solution. It's just to prevent irreversible nerve damage. But you need to take care of it definitively, and that's why you consult radiation therapy or neurosurge. Here's an image to illustrate what spinal cord compression can look like on an MRI. So here's the spinal cord, and here's the notable compression at the level of C8 to C7. Now let's move on to cardiac tamponade. So cardiac tamponade is a life-threatening emergency that arises following buildup of fluid in the pericardial cavity. And this accumulating fluid increases intrapericardial pressure above the diastolic ventricular pressure, and that in turn restricts ventricular expansion and filling. So the patients get this acute drop in preload, as well as stroke volume and cardiac output. Let's utilize this image to supplement the discussion that we started on the previous slide. So on the left, we see a heart sitting in its pericardial sac, and that contains a normal amount of lubricating pericardial fluid. On the right, we see a similar situation, except there's a lot more fluid in the pericardial sac. So when the amount of pericardial fluid becomes sufficiently high, it effectively compresses the heart and prevents it from filling during diastole. And that can lead to a life-threatening decrease in cardiac output, and you call that shock. Now, the clinical features of cardiac tamponade include distended neck veins, hypotension, and muffled heart sounds, as well as pulsus paradoxus. And the neck veins become distended because the compressed heart cannot fully fill with blood, and that causes a backup of blood into the superior vena cava and other veins in the neck, and that creates this engorged or distended appearance. And the hypotension occurs due to an acute drop in the cardiac output due to the acute drop in preload and stroke volume. And the heart sounds appear muffled because there's so much fluid in that pericardial sac. So when you're trying to listen with a stethoscope, you've got so much more water and fluid to listen through, so it sounds more distant or muffled. And those top three, distended neck veins, hypotension, muffled heart sounds, are collectively known as Beck's triad. And when you have all of those present, which thankfully you can identify clinically, you have Beck's triad fulfilled, which makes you think of cardiac tamponade. The last clinical feature, pulsus paradoxus, refers to a significant drop in the patient's blood pressure upon inspiration. So they take a deep breath in, and their blood pressure drops abnormally low. And just like with the other findings, those three that make up Beck's triad, pulsus paradoxus occurs because of the high amount of pericardial fluid exerting that compressive force on the heart. Now here's an image of distended neck veins that can be seen in a patient with cardiac tamponade. So how do you actually diagnose and treat this? Well, the diagnosis of cardiac tamponade is based largely on those clinical features. So Beck's triad plus pulsus paradoxus. And then you can support that with ECG or echocardiography. And I'll show you what an ECG or an echo look like in cardiac tamponade. But first, let's finish this treatment idea. So the treatment is fairly straightforward. You need urgent pericardiocentesis or a pericardial window. And either one of those are meant to alleviate that compressive pressure from all that fluid buildup. So you want to relieve that pressure, and you've effectively treated it. Now here's an ECG taken from a patient with cardiac tamponade, and it shows that characteristic finding that's called electrical alternans. And this finding is characterized by the alternating amplitude of the QRS wave, as you can see here. So high amplitude, low amplitude, high amplitude, low amplitude. And it just alternates. So electrical alternans. And you just think of the heart kind of bouncing around in that pericardial sac as causing this issue. Now here's an image demonstrating echo findings on a patient with cardiac tamponade. Now by means of orientation, here's the heart, and here's the surrounding pericardial fluid. And if we let this animated image play out, you can see that the heart is bouncing around in a significant amount of pericardial fluid. And you need to promptly drain that in order to alleviate the symptoms of cardiac tamponade. And visualizing that, hopefully you can see why the electrical amplitude of the QRS wave will just alternate so much, because the heart keeps bouncing around. Now let's conclude this lecture with a board-style question. A 68-year-old woman is brought to the emergency department due to acute shortness of breath that started 1 hour ago. Her past medical history includes metastatic breast cancer, for which she takes chemotherapy. Her vital signs include a temperature of 37 degrees Celsius, a blood pressure of 65/50, a heart rate of 150, and a respiratory rate of 17. The physical exam reveals the jugular venous pressure of 11 centimeters and diminished heart sounds. Electrocardiography, or ECG, reveals QRS complexes with varying amplitude. There are no ST segment changes or T-wave abnormalities. Which of the following is the best next step in the diagnosis of this patient? A. Echocardiography. B. Chest CT scan. C. Serum CKMB measurement. Or D. Serum troponin measurement. Okay, so this patient has a past medical history of metastatic breast cancer, and they present with Beck's triad. And that triad consists of severe hypotension, jugular venous distension, and diminished heart sounds. Now, all of these findings suggest the diagnosis of pericardial tamponade possibly due to that metastatic cancer. And the pericardial tamponade is actually further supported by the finding of electrical alternans that you can see on the ECG, which refers to that alternating QRS amplitude. So with all of that information, you've seen it clinically, you've got some evidence on an ECG. Now we think this patient has cardiac tamponade. So what do you do next? So the best next step is to really confirm your diagnosis. So you're going to want to get an echo. With that in mind, the correct answer is A, echocardiography. So here's the slide reminding us of the diagnosis and treatment of pericardial tamponade. So again, you're going in with the clinical information, and then you want to get an ECG and echocardiography. Rarely do you move towards treatment without getting both an ECG and an echo. So now let's discuss why the other options are incorrect. So option B, a chest CT scan, is incorrect because it's time-consuming and our patient is hemodynamically unstable. Now option C and D are incorrect because serum CKMB and troponin are measured when acute coronary syndrome is suspected. But right now, everything's pointing towards pericardial tamponade, not ACS. Especially given the fact that on the ECG, there aren't any ST segment changes or T-wave abnormalities. So again, the correct answer is A, echocardiography. And that concludes this section.